How's it going, Jace Black? Yeah, it's working.
It's so far behind right now.
That's fine.
Was I terrible? I'm sorry. It's funny because my daughter's like, so you see all sorts of people that, well, he's 6'3".
Your daughter's considerably taller than my daughter. My daughter's like,
I try to avoid it. Some things like fractures that I like need sedations. There's a lot of things I ignore.
Yeah, I think I remember. I don't want the these counts here. So we're live. Because so I remember
ass and others just like,
Yeah, that whole big friend thing.
we just like, I don't know.
getting the candid shots.
Yeah. Good for you. Are they using this?
No.
Worst set to me is like 2 o'clock in the afternoon set because like people are still stuck in traffic there and you burn for all minutes. Like kind of how you doing? Yeah, and so no one's really into it. It's like a big music festival. It's like several days and they have a weird combination of people. It's like it's kind of it's pretty famous like for like before that became really cool. No, I just
if you want, I can swing by tomorrow. Make sure you have everything.
Okay. Plus my shortcut isn't working. My link to the main server isn't working anymore.
Oh, okay. Yeah, I'll take a look at both.
I wasn't expecting those tennis shoes. I wish I was a VA. They should like send it to you. Hey guys. I think he learned the hard way. I don't know how you could get up and just like, I don't know, you could. He had to learn the hard way. You'll be sure to know. You break your hip and you just don't feel bad for it.
Okay, but I mean, you can understand.
I
Knowing both of them,
yeah.
the
Good morning. I'd like to welcome you all here to the sports medicine session on hamstring injuries, focusing on proximal hamstring issues. And we have the great pleasure of three speakers this morning. Dan Holtzman, who is one of the residents, will be talking to you about the anatomy and some of the fundamentals of the proximal hamstring and the hamstring generally. And then Kim Harmon, one of the professors of sports medicine, will be talking to you about non-operative options in treating hamstring pathologies. And then Trey Green, who's well known to you all, will be discussing surgical management of proximal hamstring injuries. So without further ado, I'll get Dan to introduce the session. Thank you very much.
All right, thanks for coming. So, first off, these are our disclosures. So in general, the way this is going to work is I'm going to start out by discussing the anatomy of the hamstring. We'll focus on the proximal hamstring origin at the ischial tuberosity. I'll then discuss the clinical presentation and demographics of patients who may present to the clinic or ER with acute or chronic proximal hamstring injuries. Next, I'll discuss the operative indications for the treatment of a proximal hamstring rupture. I'll then turn it over to Dr. Harmon, who will discuss non-operative management of hamstring injuries, including PRP injections. And lastly, Dr. Green will discuss operative treatment of proximal hamstring injuries and outcomes. We're going to start off with a couple cases. The first is a 28-year-old dancer who had one foot planted in the ground and the other above her head doing a windmill-type maneuver with her knee fully extended and her hip flexed. She felt a pop in her posterior thigh and had severe immediate onset posterior thigh pain and limped off the stage. She developed swelling and ecchymosis of her posterior thigh and was having trouble walking comfortably. She specifically had pain with hip flexion during gait, and she presented to our clinic 2 weeks after her injury. These representative MR images are T2 sequences of the left proximal thigh. The axial images on the left and the coronal images on the right show edema and hematoma at the ischial tuberosity and along the proximal hamstring tendon sheath. And you can see that the proximal hamstring tendon is avulsed and retracted about 4 centimeters from its origin on the ischial tuberosity. The second case is a much different patient in a different clinical situation. She's a 60-year-old office manager who slipped on a wet floor at work and had immediate posterior thigh pain. She was seen in the ER and by her PCP, who prescribed rest, ice, and physical therapy. 3 months after her injury, she presented to our clinic complaining of persistent weakness in her left leg, specifically with knee flexion, pain with sitting, and pain when rising from sitting. She also had occasional radicular-type electric pain that shot down the back of her leg. These representative T2 MR images show much less edema than in the acute case and don't show a lot up here, but take my word for it that there's some edema around the proximal hamstring tendon, and the tendon is avulsed about 10 centimeters from the ischial tuberosity in this case. The proximal hamstring muscles themselves are shortened and retracted as well. So, the hamstring muscle group is comprised of 3 muscles: the biceps femoris, the semimembranosus, and the semitendinosus. The biceps femoris has a long head and a short head, and the long head of the biceps, semimembranosus, and semitendinosus have a common origin on the ischial tuberosity. The long head of the biceps and the semitendinosus actually share a proximal tendon, often referred to as the conjoined tendon. The long head of the biceps, semimembranosus, and semitendinosus cross both the hip and knee joints, functioning as hip extensors and knee flexors. The short head of the biceps, which originates just medial to the linea aspera on the posterior distal femur, is important in flexing the knee when the hip is extended. This image shows the ischial tuberosity, right here, and the conjoined tendon of the long head of the biceps and semitendinosus. You can see the distinct tendinous origin of the semimembranosus here, and the close proximity of the sciatic nerve to the ischial tuberosity. This image also shows the short head of the biceps, down here, which becomes confluent with the long head distally. Distally, the biceps tendon inserts on the fibular head and the posterolateral tibia to comprise an important component of the posterolateral corner of the knee, and the semimembranosus has multiple insertions on the posteromedial tibia and is an important secondary stabilizer of the knee. The semitendinosus joins the gracilis and sartorius to insert on the anteromedial tibia at the pes anserinus as it passes over the medial collateral ligament. The long head of the biceps, semitendinosus, and semimembranosus are innervated by the tibial portion of the sciatic nerve, whereas the short head of the biceps is innervated by the perineal portion. It's thought that the increased rate of injury to the biceps femoris could be due to the asynchrony between the long and short heads as they are innervated by different portions of the sciatic nerve. This is a more close-up view of the ischial tuberosity. You can appreciate the relatively superior and lateral position of the proximal hamstring origin. You can see the conjoint tendon here and the semimembranosus. You can see the close proximity of the sciatic nerve as well. The more medial footprint of the conjoint tendon is more oval-shaped, whereas the semimembranosus is more crescent-shaped. And both histologically and anatomically, there's some confluence between the sacrotuberous ligament and the conjoint tendon seen here. This is a close-up view of the semimembranosus origin. This is semimembranosus tendon and the semimembranosus origin. It has an accessory extension which traverses more horizontally onto the tuberosity, and it's thought that this helps to disperse force at the proximal origin of the semimembranosus and corresponds to the fact that this is the least injured proximal hamstring tendon. This T1 MR image provides some radiographic correlates to the anatomy we just saw. You can see the close proximity of the sacrotuberous ligament here to the conjoint tendon, as well as the close proximity of the sciatic nerve to the ischial tuberosity. And again, this is the greater troch. You can see the more lateral position of the semimembranosus. Finally, this is a potentially precarious position to be operating because of the close-by neurologic structures. In an anatomic study with dissection of 14 fresh frozen cadavers, the average distance between the lateral border of the ischial tuberosity to the sciatic nerve was measured and found to be only 1.2 centimeters from the edge of the ischial tuberosity, referenced by this oval line here. This is the 1.2. In addition, they looked at the distance from the most distal aspect of the gluteus maximus muscle belly and found that the inferior gluteal nerve was only 5 centimeters from the edge of the gluteus maximus muscle belly, and thus recommended that in surgical cases the retractors be placed only at a depth of about 4 centimeters from the inferior aspect of the gluteus maximus. So when we think of hamstring injuries in athletes, headlines like these come to mind. These headlines make it clear that hamstring injuries are common in all types of sports and can affect elite athletes, resulting in substantial time lost from play. Now, you may be familiar with this video. Let me try to get it going here. So that's Josie Altidore from the U.S. soccer team sustaining a severe hamstring injury in the U.S.'s first game against Ghana. Most of you probably know that he was unable to play in any subsequent World Cup games after that. So it's important to distinguish, however, that the common type of hamstring injury referenced in those headlines and shown in that video is different than really what the focus of our grand rounds is today, which is proximal hamstring tendon ruptures. Proximal hamstring injuries are very rare, they're debilitating injuries, and they've only been described in great detail within maybe the last 7 to 10 years or so. Hamstring injuries, as an all-encompassing group, are extremely common. They represent up to 29% of all injuries in various sports, and they're the most common lower extremity injury in athletes. They are most commonly a strain of the musculotendinous junction, and despite extensive studies, there's still only mixed data on risk factors, with prior hamstring injury being the most commonly identified risk factor in various studies. Athletes who rapidly accelerate, like sprinters or soccer players, are particularly at risk, and most injuries occur during non-contact activities. Many sports-specific studies have been conducted examining hamstring injuries, and again, these are commonly strains at the musculotendinous junction. In Major League Baseball, hamstring injuries are the number one time loss injury, representing 5.7% of all injuries, with an average time loss of 24 days. In the NBA, it's the fourth most common injury, and in Australian rules football, hamstring injury is the most common injury reported and has a 26% recurrence rate. It costs about 40,000 Australian dollars for every hamstring injury that occurs, both in treatment costs and in salary costs due to time loss. Soccer has been the most extensively studied. A meta-analysis found that hamstring injuries represent about 12 to 16% of all injuries in soccer players, and that prior hamstring injury was a commonly identified risk factor amongst these studies. When we're focusing on proximal hamstring injuries, what we're talking about is avulsion of the proximal hamstring tendon from the ischial tuberosity. This is the most severe type of hamstring injury, and the long head of the biceps is the most frequently injured, followed by the semitendinosus and then the semimembranosus. The mechanism of injury is typically an eccentric contraction of the hamstring muscle with the knee extended and the hip flexed. In contrast to studies of hamstring injuries at the musculotendinous junction, very little has been written about proximal hamstring injuries, particularly in elite athletes. In the NFL, over a period of 18 years, 10 proximal hamstrings were identified and treated surgically. Results were mixed, with 5 players returning to play and having meaningful post-injury careers, but 5 of these players played in no games at all or only in 1 game subsequent to the injury. This poor rate of return potentially suggests a degeneration in function at an elite level that can be associated with this severe type of injury. Athletes who are particularly at risk for proximal hamstring avulsions include those with high energy ballistic activities or those who find themselves in a position of hip flexion and knee extension like skiers and weightlifters. Hurdlers, because of their combined hip flexion and knee extension, are also at risk. And in multiple case studies, one of the largest groups of patients that have been identified are water skiers due to the position of knee extension and hip flexion that is required to get up from the skis on the water. So in the acute setting, athletes who have sustained a proximal hamstring injury will usually report a sensation that someone kicked them or threw something into their posterior thigh. This is accompanied by an audible or palpable pop. Again, it's usually associated with an eccentric contraction of the hamstring with the knee extended and the hip flexed. They report difficulty walking smoothly, decreased hamstring flexibility, and can have pain when sitting for prolonged periods of time. In patients with chronic proximal hamstring avulsions, persistent weakness with hip extension and knee flexion and pain at the ischial tuberosity while sitting is a common complaint. Patients may note a posterior thigh deformity. A serious complication of non-operative management can be development of something called hamstring syndrome, which is due to scarring of the sciatic nerve to the retracted stump of the proximal hamstring tendon. This can result in buttock pain at the ischial tuberosity that's painful with sitting, sciatic tension signs, and radiculopathy with pain radiating posteriorly and distally in the leg. In this chronic setting, neurolysis of the sciatic nerve should be performed with proximal hamstring repair. The neurologic sequelae of proximal hamstring injuries are often underappreciated and difficult to diagnose. Again, chronic injuries can be associated with sciatic nerve tethering and tension signs. This may manifest as a radicular electric type pain shooting down the posterior thigh. It may result in subtle weakness with ankle dorsiflexion or eversion. These symptoms can often be misinterpreted as lumbar radiculopathy, which is a much more common complaint in sports and orthopedic clinics. Patients may also have painful neurologic sequelae after proximal hamstring repair or reconstruction due to sciatic nerve irritation or neuropraxia, or may develop dysesthesias from injury to the posterior femoral cutaneous nerve or hip extensor weakness from injury to the inferior gluteal nerve. Patients may also develop pain syndromes such as complex regional pain syndrome or CRPS pre or post-operatively. This is distinguished by pain out of proportion to the clinical exam. It's associated with prolonged immobilization or disuse and tight dressings or wraps. Clinically, you may see an exaggerated sympathetic response with warm, red, clammy skin. As if this wasn't confusing enough, there's a case report in the literature of a patient developing a posterior thigh compartment syndrome after proximal hamstring rupture with progressive neurologic deficits that was treated with fasciotomies, evacuation of hematoma, and repair. So clinically, patients often present with a stiff-legged gait, weakness with hip extension and knee flexion, and varying levels of posterior thigh ecchymosis, which signal a higher grade injury. They may have a positive bowstring sign, which is the absence of palpable hamstring tendons distally. In chronic cases of proximal hamstring avulsion, there may be a visible deformity of the hamstring muscle complex with resisted hip extension. And hamstring injuries come in escalating levels of severity. The pediatric equivalent in skeletally immature patients are apophyseal avulsion fractures. These can often be treated non-operatively, even when fairly displaced, depending on age and skeletal maturity. Incomplete tendon avulsions from bone may occur, seen here. Complete tendon avulsions without retraction may be seen. And finally, complete tendon avulsions with retraction are the highest grade injury and may or may not be associated with sciatic nerve symptoms. So as with most procedures in orthopedics, as the pathology is more widely recognized, the indications for surgery have gradually expanded. In the acute setting, surgical indications are generally well accepted. Single tendon avulsions or 2 tendon injuries with less than 2 centimeters of retraction are treated non-operatively. 2 tendon avulsions with greater than 2 centimeters of retraction, and 3 tendon avulsions are treated with acute repair. Indications for repair or reconstruction of chronic avulsions are less well defined, but surgery may be offered to patients with pain or functional deficits associated with a chronic retracted tear. Sciatic nerve symptoms are an indication for neurolysis in the acute or chronic setting. So now I'm going to turn it over to Dr. Harmon, who's going to talk about non-operative treatment of hamstring injuries.
I'd like to thank you for inviting me today. And let's see here, how to get this forward. Right. It's not moving forward here. Okay. All right, so today I'm going to talk about acute injuries. I'm going to talk a little bit about the pathophysiology, and talk about the treatment in muscle injuries in general and hamstrings in particular. And then I'm going to talk about chronic hamstring injuries, tendinosis, chronic partial tears, and then the radiating pain that sometimes you get. We're going to go back and talk a little bit about the pathophysiology of muscle in general so that you can understand the rationale for some of the treatments that we do. And when I'm talking about muscle injury, I'm going to talk about elite athletes because those are primarily the people that we're going to be really trying to be aggressive with. So when a muscle ruptures, what happens first is that there's a tremendous amount of bleeding. That bleeding causes a very large inflammatory response. With the inflammatory response, there's a clot that forms, and neutrophils begin to infiltrate quite quickly, as early as 1 to 2 hours. Interestingly, the time of peak injury does not occur when the injury actually occurs, but it occurs at 24 to 48 hours later. And that's what's referred to sometimes as a respiratory burst or the secondary injury. And if you can block that respiratory burst, you can prevent some of that secondary injury. So if they take knockout mice that don't have neutrophils, that secondary injury is much, much less. Or if they give antibodies to neutrophils, that secondary injury is much less. And so some of the targets in terms of reducing muscle injury have been to prevent that secondary injury. Next, after that, the regeneration phase happens. Growth factors are really what play a critical role here. And when we're trying to look at muscle injury, this is where the growth factor therapy comes in to try and influence the different growth factors. The two key growth factors that are probably important are transforming growth factor beta, which leads to fibrosis, and then IGF-1 or insulin-like growth factor 1, which leads to myotubule formation and muscle formation. And what happens in this phase, the quiescent satellite cells that are already in muscle get activated, and they can really differentiate into two things. They can either become myoblast or they can become myofibroblasts, which are going to make scar tissue. And then the scar will begin to mature, and you'll get varying degrees of either muscle, which you see in red there, or scar, which you see in blue. And really, the fibrosis, the scar, is a key inhibitor to healing. And so if you get a lot of scar, what happens is that the myofiber stumps can't come together, and actually the axons of nerves can't come and attach to the myofiber stumps, and so then you actually get a secondary denervation atrophy. So with initial treatment of any muscle injury, and so this goes for hamstrings as well, what we try to do is control the respiratory burst. And so the athlete's best friend, of course, is ice, and so we do aggressive icing, compression, and this is really highlighted in quadriceps injuries where we put people into forced flexion for 24 to 48 hours to try and limit some of that bleeding. You can't really do that in hamstrings. There's been some question of using prednisone for the first 24 to 48 hours to control that respiratory burst. There's studies in animals where they've used prednisone at doses of 25 milligrams per kilogram, which is a huge dose, and they show that they end up with muscle degeneration. In smaller doses, it may help to control that respiratory burst. And then NSAIDs, which has been traditionally what we've leaned on, actually probably leads to fibrosis in the long term in that muscle injury. And there's lots of literature that would prove that. And so I've actually gone away from using NSAIDs in acute muscle injury, although it's hard to convince the athletic trainers and athletes to avoid them because it does lead to increased fibrosis. And so there's been a lot of different things that people have tried to get athletes back to play because there is this tremendous pressure to get people back to play. And primarily in elite sports, it involves injecting things into the muscle belly and the hematoma that's created. And so I'm going to go through each of these just very quickly. Local anesthetics are myotoxic, and so some people will just inject local anesthetics into the injured hamstring so that people can go back to play. It's myotoxic, it doesn't work very well and shouldn't be done. Trameal and Actovegin, I don't know if anybody's heard of them. Those are natural anti-inflammatories. They're widely used in Europe. All the soccer players in Europe will get these injected. They're not used very much here. There's absolutely no literature on whether they're effective or not. But the soccer players, here I'm the regenerative medicine consultant for the Sounders, and the guys will all come in and they'll ask for that. It's available here, but I haven't used it. I'm going to talk a little bit more about the use of corticosteroids for injectables and platelet-rich plasma in hamstring injuries. So this article came out in 2000, and it's a little bit surprising. I read it again the other day that this actually got published, but what basically, this is pretty common practice in the NFL to inject corticosteroid into a hamstring strain to get people back. And what this article showed was that they took 58 players that had pretty severe hamstring injuries. So hamstring injuries that people could not, they lost strength with, they had defects with, so second or third degree hamstring injuries. They injected corticosteroid and local anesthetic into the hamstring defect, and none of the players, or 49 of the players didn't miss the game. 8 of the players only missed 1 game. And so that's pretty amazing because typically a second or third degree hamstring injury is a 4 to 12 week injury. I would dare say that there's some secondary motivation for NFL players to get back to the game, and so that this isn't really a real-life situation. When you look at the evidence in terms of whether this should work or not, there's an animal model that shows no difference between injecting saline and corticosteroid into a injured muscle. And if you inject corticosteroid and local anesthetic into a muscle, which is what you do when you do this, it's actually more myotoxic than just the local anesthetic alone. So this probably isn't actually a good idea either, although it's commonly done. And so then the question becomes, what about platelet-rich plasma? This became very, very popular in 2009 after Hines Ward, about 2 weeks before the Super Bowl, got a second-degree MCL strain. He had platelet-rich plasma. They wrote about it in the New York Times, and all of a sudden everybody wanted PRP. And so the problem with platelet-rich plasma in a acute injury is it's really hard to tell whether it's working because with a muscle strain, it's very difficult to predict how long it's going to take somebody to get back to play. And so to decide if an intervention works or not is difficult. But this study actually just came out within this last week, and it was in the New England Journal of Medicine. And this is, I think, really answers the question. And what they did, it's a double-blind, placebo-controlled randomized study. They took 80 athletes, and they put them either into a saline group or into a platelet-rich plasma group. Now, there's different types of platelet-rich plasma, and it's probably important what type you use, particularly in a muscle injury. You don't want to add neutrophils to it. And so they actually used the correct type of platelet-rich plasma here. It was neutrophil-free. They did 2 injections, one at 5 days and one 5 to 7 days later. And what they found was the average return to play in the platelet-rich plasma group was 44 days, and in the PRP group, and in the placebo group, it was 42 days. The re-injury rate was similar in both groups as well. And so it doesn't appear that platelet-rich plasma really got people back any quicker than the saline did. And, you know, actually, when people ask me, does platelet-rich plasma work in acute muscle tears, I would tell you that that's sort of been my clinical impression, that I don't know whether it gets people back quicker or not. we do this for almost all of the muscle strains in the sounders. They get 35 a year, or last year they did. It creates a huge amount of time loss for them, and most of them or a lot of them are European, where this is very common practice. And what I think may happen with the platelet-rich plasma is that the platelet-rich plasma has a lot of insulin like growth factor 1, and I think that it may encourage a better repair. And so instead of getting that fibrosis, that it may encourage a better repair. And so the one thing that they didn't do in that study that they should have is they should have biopsied the muscles, although I'm sure people didn't want their hamstrings biopsied. So what's best practices in a strained muscle? Ice and aggressive ice, compression. I think avoiding NSAIDs, which is something that's hard to get people to do, is actually the thing to do. And what I think why people think that the corticosteroids in the NFL players may work is because draining hematomas really seems to be helpful. And with the advent of ultrasound, as we're ultrasounding these pulled muscles, we find hematomas all the time. And if you let that hematoma in there, what happens is that it organizes and it prevents that muscle from healing. And so if you drain it, people get better much quicker. And so now we're going to talk a little bit about proximal hamstring tendinosis. I see a great deal of this in my practice. It's very common in runners, particularly older runners, 40 or 50 years old, that are trying to keep their mileage up. People come in and they present with pain with use, pain with sitting, and the pain may radiate down to their foot or the back of their leg. On physical exam, they'll have tenderness over their ischial tuberosity. They will have pain with resisted use of their hamstrings, and this is really critical because a lot of people have buttock pain that isn't related to hamstring tendinosis, and so you need to differentiate the people that have hamstring tendinosis related pain from other causes. And so I get an MRI in people. Ultrasound, which I use a lot of, and I don't get MRIs for a lot of things, but for hamstrings I need to because the hamstrings are deep and they're curved, and so you get, I can't reliably tell tendinopathy with a ultrasound, so I get an MRI. And you can't have any other features with this radiating pain to the scrotum or the labia because that indicates something else and people don't do well. And so the thing with proximal hamstring tendinopathy on MRI, it's sort of like a bulging disc. In people over 40 or 50, if we took 100 asymptomatic 40 or 50-year-old runners, it would be present in a lot of people. And so you really need to correlate your findings on MRI with your findings on exam. And if you look right here, here's the attachment of the hamstring along here. And there's the signal change right there. You can see on the opposite side that it's not present. And on the axial view right here, again, you can see the signal change there, and it's not present there. And as Daniel was saying, you can see the close approximation of the sciatic nerve right there and why people might get radiating symptoms. So the treatment of any tendinopathy, not particular hamstring, but this is what we do, is the first line treatment is eccentric exercises using physical therapy techniques like A-stim or Graston, which are deep cross-friction massage. You can use nitro patches. They don't work very well in hamstring because that's a deep hamstring. And then we'll talk more about either autologous blood injections or platelet-rich plasma injections for these. We started out with autologous blood injections about 6 years ago, and then we switched to platelet-rich plasma injections mostly because of consumer demand. So after we'd been doing platelet-rich plasma injections for about a year, we thought, gosh, this works pretty well, but we didn't know whether it worked well because we just thought it did or whether it actually did. So we sent out a survey to our patients. We got 119 people to answer, which was an 83% response rate, which was pretty good. And we surveyed on just whether it worked or not. The average age of our patient was 49, and by the time they reached us, they'd had symptoms for almost 3 years. And what we found in that retrospective study was that there had been an average decrease in pain of about 5 in a visual analog pain scale, that 60% of them, a little over 60%, thought that they were mostly or completely improved. About 80% had had some significant improvement. 90% thought they'd recommend it to a friend, so that was pretty good. And there's right now about 15 studies on tendons that are in the literature. There are 4 double-blind placebo-controlled studies in the literature on tendons. There are none on hamstrings, but they all suggest that there's some benefit to platelet-rich plasma in chronic tendon injuries. So we've done a prospective study where we followed out our patients prospectively. Again, our demographics are the same. Around 50 seems to be a pretty bad age for tendons. By the time they make it to us, people have had symptoms for almost 3 years. They've tried multiple rounds of physical therapy, massage, acupuncture, corticosteroid injections, you name it. And what we did with this is we did outcome measures at presentation, 6 weeks, 12 weeks, 6 months, and a year, and then visual analog pain scales and a site-specific validated outcome measure. And for the hamstrings in particular, we used the hip outcome score. These are the areas that we treated, and you can see that I would actually say that proximal hamstring is probably my biggest customer now, but in this particular group, it was my second biggest customer. And our outcomes is that at 6 months that we have about 60% of people mostly are completely better. And that is, I think, pretty good for a group of people that have no options other than surgery, and they've had something for 3 years and nothing's worked. Our outcomes for other tendons are similar, except for lateral epicondylosis, except for plantar fasciosis. It's probably a little bit better. And these are the site-specific outcome measures, and they all meet the minimally clinically important change for that measure. And so if you look at this graph right here, this is sort of what you see. We have 20% of people that don't respond. I can't pick them out. There's people I think that will never respond that have a good response, and there's people that I think are slam dunks that don't get better. And then the rest of the people sort of get better at different rates. We have about 20% of people that are real slow responders, and then other people are quicker responders. And when people come in at 6 weeks and I ask them how they're doing, they all say, I'm doing a little bit better. It's hard to tell I'm not doing anything. But by 12 weeks, you can really tell who are the quick responders and who are the slow responders. And the good news is if you're a slow responder, if you just sort of hang around long enough, you'll eventually get better. And so typically, if you're like a typical patient. And so there's some people that come in and they're like, it doesn't hurt me to walk down the stairs anymore, so I'm good just waiting. And there's other people like my triathletes that say, I spend more money. The PRP injections are cash. They're not covered by insurance on pedals, and I need to get better tomorrow. And so then we'll do a second injection on that. And that's really a time versus money decision with the PRP. Now, with the radiating symptoms, you can see how close that sciatic nerve is to the proximal hamstring tendon. And so you can get entrapment of that nerve from scar tissue. And what we've been doing with that is we've been doing a technique called hydrodissection. And that's where we use fluid to actually try and peel away or dissect the tissue from the sciatic nerve under ultrasound guidance. There's very little risk to doing this, and it seems to be very promising. And the first one that I did for this was actually a patient of Trey's. He actually couldn't move his toes and had a lot of hyperalgesia over his buttock, and I didn't think it would work, but went ahead and tried to do it. And the patient called me on his way home in the car and said, gosh, I'm moving my toes for the first time in 6 months. So that was pretty encouraging. And I've since done a lot of this, and some of the people that have that radiating buttock pain from sort of irritation of the sciatic nerve from either healing of the hamstring tendon seem to get some relief from that. And so I think that we'll see more of that in the future. So in conclusion, acute injuries with retraction, I really think need to be surgically repaired. I see a lot of people that haven't had them repaired, people that are maybe older, 40 or 50, and not very active or minimally active, and people don't like to operate on this necessarily, and they just do horribly, and there's not much after it's been retracted that can be done for them. Acute grade 2 to 3 injuries should get aggressive rehab, avoid NSAIDs, drain the hematoma. Whether PRP is helpful or not, it's not going to get you back quicker, and whether it ends you up with a better repair or not, I don't know. Chronic proximal hamstring tendinosis can be treated with PRP, but it should be a treatment that's used after other treatments fail. It's not a first-line treatment, but it can be effective before you try surgery. So, Trey?
All right. So we're going to talk about the surgical treatment. We're going to talk about some of the acute repair issues as well as the chronic considerations and some outcomes. So with the acute repair, we're going to talk about first the surgical timing. The definition of acute versus chronic has changed over the years, and so early literature uses 6 weeks. The most recent things in the last decade, 4 weeks or less is the definition of an acute repair. It's ideal to get it pretty quickly within the first couple of weeks, but many times the patients don't present to us quite that quickly. So oftentimes we operate them when they arrive. So it's a general anesthetic in the prone position. Chest rolls, knee pads, and ankle pillow are helpful. A little Trendelenburg is a little trick to improve your exposure to the ischial tuberosity. I drape the leg like this, so using some adherent surgical drape to drape off the perineum, leaving the limb free so you can move the knee. That's very helpful to assess tension, and particularly in the chronic injuries can be really useful to mobilize the tendon as well. I prefer a transverse incision in the acute cases because it's a much better cosmetic incision. It's right in the gluteal fold, and it doesn't have to be terribly big. About 10 centimeters is all you need. If you're going to do a longitudinal incision, then it's starting at the gluteal crease and going distally. You don't need to go across the gluteal crease, and the old adage about your incision size matching your dress size is true for this kind of exposure as well. Borrowed this from Dr. Hoppenfeld, but this is the best diagram I've seen to illustrate some of the dangers of this approach. It's, theoretically quite simple. It's just lifting up the gluteus maximus. It's right under the gluteus maximus. And so the dissection is under the gluteus maximus. You heard from Dan about the inferior gluteal nerve, and it's coming out right underneath, and it's about 4 to 5 centimeters away from the distal edge, and so smooth retractors under there are helpful. I like to put a retractor right on the bone, so you can put a Holtzman or a pointed retractor down there. A wide one is really helpful as well, but you do have to be careful on the way down. The second consideration is the posterior femoral cutaneous nerve. So this is a little nerve that comes off separately, and it comes out under the piriformis, separate from the sciatic, and so it's a little nerve. It's lateral to the ischial tuberosity up proximally, and then it becomes on top of the fascia of the hamstrings to run down the thigh. So this nerve is quite variable in the size and also the location of it. I look for it each time, but I don't always see it in an acute repair or in a chronic repair. The sciatic nerve is more lateral. I'll show you some more pictures of that a little bit later, but I don't dissect that in an acute case just by palpation. Looking at the fat stripe, it's usually pretty easy to tell where that is. And so retractor placement laterally is got to be really careful. You've got to be careful that you're not too deep, and so retractor placement laterally, you have to be really careful and put them just under the hamstrings with something smooth. So identification and mobilizing the tendon is the next step. I like to tag it and grab it with a suture so you can pull it. And acutely, it's pretty easy, just finger dissection. Did a little study about the distance to the first motor branch, and so the average is about 4.5 centimeters down from the ischial tuberosity, but the closest branch we found was as close as 2 centimeters down. So got to be careful with dissection mobilization, but also then suture placement. That's a consideration as well. Exposure of the ischial tuberosity is always a little bit more lateral, and it's an oblique surface, not really the bottom of the ischium where these attached, so it's more higher and up on the side than you would expect on your first time. That picture doesn't show too well, but preparation of the ischial tuberosity down to some bleeding bone, metal anchors, and a high-strength suture. We use double-loaded number 2 sutures in a Krakow fashion with just 3 or so, sometimes 4 stitches to get that accomplished. So we're trying to get an anatomic repair, and the rehabilitation is quite variable in the literature. Basically, at the time of surgery, you can assess how much tension is on the repair with the degree of knee flexion. And so for me, I like to see wherever that develops tension and then add 30 degrees, and that's where I'll put people in a hinged knee brace with an extension stop at that level, give them crutches, and they don't really weight bear until they get out to full extension. So basically start out with a brace usually locked acutely, maybe at 30 to 60 degrees, and advance 30 degrees every 2 weeks. When you get out straight, then I allow weight bearing, and then we'll start mobilizing, walking, and strength training at about somewhere between 6 and 8 weeks. For chronic repairs, it's a longitudinal incision because you're going to have to do some more significant dissection. One of the things you'll notice about this picture on the right is that these branches are very close, or they're very short, and so the sciatic nerve is not far away. If you think about, well, if this tendon ruptures and retracts distally, what's going to happen? Well, because of the tethering of those little nerve roots, these things are going to get closer together, actually, as it retracts. So these two things are going to be side by side, and that's where dissection of the nerve in the chronic situation is really important. And it can be a quite difficult dissection based on how long and how much scar formation, but that is the difficulty of a chronic case. So mobilizing the tendon and making sure that you feel when you put your pulling stitches in it that it feels the bounce of a muscle, not scar tissue, is really important. The goal is to mobilize it all the way back and do a delayed primary repair in the chronic situation. And interestingly, you can do that sometimes years later, so you can still mobilize that tendon. If you have retraction less than 5 centimeters, then most of the time you can get it back all the way to the bone without a tendon graft. When you get around 5 centimeters, then you need to start thinking about, well, you might need an intercalary tendon graft, and if you do that, an Achilles graft, and using a bone plug and putting it in with an interference screw into the ischium is usually a good way to do it. The ischial footprint is somewhere around 1.5 centimeters to almost 2 centimeters in the AP, and maybe 5 or 6 centimeters in length. So you can put in a plug that's maybe 7 or 8 safely in most folks. Rehabilitation-wise, We try to slow them down a little bit. We'll add 2 weeks more to our initial brace time to allow for some additional healing before we start unlocking it and mobilizing and weight bearing. Debridement of these tendons, you heard about the results is imperfect with PRP injections to some of these tendinosis problems and these low-grade injuries that perhaps are treated conservatively for a while. So partial tears that either don't get back or tendinosis cases, debridement of that degenerative tendon is the surgical approach. Doing less of this now that PRP is around, and the people with PRP who fail PRP and still go to surgery, they seem to have a less good outcome with debridement. If it's more than about 2 square centimeters of tendon involved, repairing that tendon is important. Neurolysis in the acute setting for acute repair, I only perform if there are sciatica symptoms. Try not to dissect out the nerve. In chronic situations, it is most always necessary to do that, and that is a difficult and time-consuming thing. So outcome-wise, there are very few studies that actually have functional scores. This is a more recent thing. There's a lower extremity functional score that a couple of studies have used. That's a score that goes up to 80 maximum. And so acute repairs get somewhere around 75, 76 points on this scale. So that's about 94% of the total. Chronic don't do quite so well, maybe up to 89 or 90% of the functional score. Strength-wise, we don't have good data on the difference between acute and chronic, but a repaired hamstring, if you can get it back to the ischium, typically has something around 80% of the contralateral strength. Interestingly, a non-operative study who looked at this group, now this is an older group of folks treated conservatively for retracted tendon tears, average age of 58, got about 60% strength back. Satisfaction is pretty good with acute repairs, 95%, chronic 85%. And the interesting thing is, though, despite the fact that some of the non-operative folks did pretty well on the functional scale, they were less happy and second-guessed their decision for surgery pretty frequently. And so they were less satisfied with their non-operative treatment than you might have expected based on their pain and functional scores. Return to sports is pretty good. For acute tears, it's 96%. But that 96% is basically at the length of the studies, which surgical studies are usually 2 to 3 years in follow-up. So between 6 and 12 months, it's only 80%. So patients who get a repair are probably not going to get back, or a lot of them are not going to get back until between 7 and 9 months. The chronic do a little less well, 75% get back to the same level of sports, and the non-operative folks, it's still fairly decent, 70%. Complications with the surgical approach is actually pretty high when you ask a lot of questions. A lot of the literature early on, if you don't ask, then I guess it doesn't exist, but that's why incisional numbness has really wide variety of numbers there, between 10 and 60%. So the more questions you ask about it, the more folks you find with it. Posterior thigh numbness, again, it's actually fairly frequent. Sciatic symptoms, so even after acute repairs, sometimes with the scarring, you can get some sciatic symptoms. They're more frequent with the chronic. Wound healing, because you sit on this incision, 4%. Exercise pain and cramping, up to 40%. So this is more of a sort of a claudication thing, may have to do with the loss of some of your vascular supply as part of this injury. And the re-tear rate is fairly low, about 3%, but higher than some of our other surgical tendon repairs. For young folks, typically healthy people, I will recommend surgery for folks that have 2 or 3 tendon tears that are displaced, and so depending upon their activity level and their desires, you know, the 2 centimeters is a relative indication for acute repair. Anybody who's physiologically older and lower demand, I'll still do conservative treatment on them. We'll talk about an acute repair, particularly if they present early. But the folks who present later in this physiological, older, lower demand, and we're in a chronic situation when we're talking about the surgical discussion, then typically I will recommend conservative treatment, and if it doesn't work out to their satisfaction, then come back and do a later chronic repair and potentially an allograft reconstruction. All right. Back to our cases. So, Bruce, you want to go through some of these?
If there are any questions anybody has that they'd like to ask the panel? Ted?
Trey, I'm interested in whether you monitor these cases because, you know, we have sophisticated monitoring now, and so I wonder if that would add to your safety of working around that sciatic nerve. We should be able to tell you if you're irritated at all or you retract on it. Just wondered if you'd used it.
I have never used that, Ted, but that's an excellent idea.
Ted, I use it routinely now, having gone and had to salvage a guy who divided a sciatic nerve in this case. And the key is to make sure the anaesthetist doesn't paralyze your patient, because then it becomes of no use. So it's very important that you prepare the anaesthetist he can use it briefly during the intubation stage. You get them prone, and then you want a non-paralyzed patient. You use the nerve stimulator unit that the anaesthetic staff use for their nerve blocks, and they have a sterile bag that it goes in, and it connects to the anaesthetic box where they can turn up or down ramp up or down the volume on the nerve stimulation. So you can tell pretty accurately how close the nerve is by how low a frequency or how low a pulse you have, and whether the nerve is stimulated or not. You have to be able to examine the toes while you're doing that.
Bruce.
Oh, Keith, sorry.
So, just to be clear, I mean, this was looked at extensively for acetabular fractures in the 90s, and the bottom line was it added upwards of, if we're talking about full SSEP monitoring, it added an incredible amount of time and cost, and ultimately its predictive value as far as prevention of complications were not felt to be worth it. So sounds like this is completely different than what you're doing, which is basically local stimulation and sort of the poor man's SSEP by looking at motor contraction.
Yeah, having trained in a developing nation, Keith, there's no doubt that direct nerve needle stimulation of the nerve in your operative field is an effective way of identifying where the sciatic nerve is. So you can use that, you can either not expose it but know where it is, or you can identify it and confirm that it is in fact the sciatic nerve, which in some of these very scarred chronic cases is surprisingly difficult to determine. Professor Madsen.
I just wanted to give Dr. Harmon some feedback. I referred her a 31-year-old obsessive compulsive marathoner and triathlete who had an atraumatic proximal hamstring tear to the point where she couldn't walk up and down stairs. Dr. Harmon and Dr. O'Kane treated her with a PRP injection, and I must say I was highly skeptical of this procedure, but for whatever reason, I just got an email back saying that last week she biked 250 miles with a 20,000-foot vertical gain with no symptoms, so thank you for that.
The other interesting thing that Dr. Harmon talked about was this neural prolotherapy, and it's interesting, there's been an increasing volume of presentations of this at sports meetings that I've been to, and there's no doubt that it carries some value in I don't know whether it's neural dissection, but there's certainly some value in neural prolotherapy in those patients who have a large component of neural symptoms associated with their tendon or scarring. And it's becoming a reliable outcome in some pretty well constructed studies now, even for patients with sciatic type symptoms from disc related disease affecting athletic performance, where they do prolotherapy along the line of the nerves. There's been, for me, I've seen some people who've been treated this way who've had spectacular results. So it's like, miracle medicine in some cases in patients who've had chronic pain associated with neural symptoms for a year, even greater than a year. So it is an interesting phenomenon. Unfortunately, we don't really know how it works effectively to truly identify those patients that will benefit. Are there any other questions? I think we've used up our allotted time, so I'd like to thank the speakers who presented and hopefully gain something for you.
Can I get your guys' photo together?
Yeah, thanks. Thanks for that. Can you just send me the talk at some point?
Yeah.
So I've got that stacked away on my side.